Let us now discuss the different pediatric cardiovascular disorders. First, we have to review the cardiovascular system. When we talk about the cardiovascular system, we deal with two important structures, the heart and the blood vessels. Cardiac adaptations must begin right after birth. And such adaptations are the fetal structures like the foramen ovale and ductus arteriosus. These must immediately close. After these, the heart can be thought of as consisting of two pumps. The heart has four chambers, the right and the left atrium, the right and the left ventricles. Atrium means they collect blood, ventricles mean they pump blood. There are four valves, the pulmonary valve and the aortic valve, the tricuspid valve, and the mitral valve. There are also four great vessels, two of which are arteries, the aorta and pulmonary artery, and the two are veins, the vena cava and pulmonary vein. Now, how does blood go in and out of the heart? Everything starts from the vena cava. Unoxygenated blood enters the vena cava. It's a vein. The blood is then collected by the right atrium. Anoxy blood enters the tricuspid valve, then goes to the right ventricle. The right ventricle then pumps the anoxy blood, entering the pulmonary valve, going to the pulmonary artery. The pulmonary artery brings the anoxy blood to the lungs. From the lungs, anoxy blood becomes oxygenated. Then, the oxygenated blood will then go to the pulmonary vein, collected by the left atrium. So, oxy blood from the left atrium enters the mitral valve as it opens. The left ventricle now pumps the oxy blood entering the aortic valve through the aorta. The right side of the heart contains anoxy blood. Again, it pumps blood to the lungs, where it is oxygenated. The left side pumps the oxy blood to the peripheral tissues through the systemic arteries. After supplying now all the nutrients and collecting the wastes from all our cells, from the organs of our body, the now anoxy blood returns again to the heart, through the veins to the right side of the heart, through the vena cava, where the cycle begins again. Contraction of the chambers, it is termed systole. Depolarization, it is also the first heart sound, the S1, the lub. While the relaxation is termed diastole, synonymous with repolarization, the second heart sound, the S2, and the dub. The blood vessels are all intertwined together. It is all connected to the heart and the other organs of the body. The arteries are blood vessels wherein the movement of blood inside is away from the heart. A smaller artery is arteriole. Veins, movement of the blood inside veins are towards the heart. A smaller vein is venule. The capillaries are the smallest blood vessels of all. This is where actual exchange of gases occur, as well as of the nutrients occur. Box 41.2 shows the assessment findings of a child with the cardiovascular disorders. It has discussed their general appearance as well as the vital signs. The following are expected in a child with a cardiovascular disorder. All these signs listed in the slide show ineffectivity of heart to pump blood. The table 41.1 shows the abnormal pulse patterns. Tachycardia, more than 160 for infants and more than 100 for children 3 years old and above, needs investigation, and it is significant if persists, especially during sleep, when excitement and activity is removed. Table 41.2 shows the comparison of innocent and organic murmurs. Please study them. A heart murmur is an unusual sound heard between heartbeats. Sometimes it's like a whooshing or a swishing sound. Functional, insignificant, or innocent murmurs may be harmless. They reflect normal variation in heart or pulmonary artery. But nevertheless, murmurs also signify cardiovascular problems. For the blood pressure, usually systolic 60 to 85, diastolic 40 to 55 for normal. Then it increases. RR, check also for rapid respirations. Diagnostic tests. An ECG or electrocardiogram measures the electrical activity of the heart. An X-ray, the upper GI series, fluoroscopy, and echocardiography are all tests to locate structures of the heart and the blood vessels. A phonocardiography measures heart sounds, and an exercise test with the use of a treadmill assesses how well the heart can tolerate increased demands. For laboratory tests, usually problems of the cardiovascular system involves polycythemia, an elevated ESR or erythrocyte sedimentation rate, abnormal blood gas levels, and low oxygen saturations. For surgeries and medications involving the cardiovascular structures, it's also important to check blood clotting, sodium, and potassium. These are the general interventions with different cardiovascular disorders. One is cardiac catheterization. It's a procedure where a small radio-opaque catheter, probably with a dye, is passed into a large vein. It could be either the arm, the neck, or the leg veins, which is directly connected into the heart. It could be done in the OPD under conscious sedation. There are two main purposes. One is diagnostic, and second is interventional. For diagnostic purposes, cardiac catheterization can secure blood samples, or it can also diagnose heart problems because this procedure can help visualize the cardiovascular structures. It can even record electrical activities such as arrhythmia. Interventional because it can correct an abnormality. For example, it can dilate narrowed valves by the use of a balloon-tipped catheter which is being inserted. Second is cardiac surgery. The open heart or intracatheter surgery remains the chief cure for many congenital heart diseases. This is done through a cardiopulmonary bypass or ECMO, extracorporeal membrane oxygenation. So what is this ECMO? It is where venous return from the right atrium or vena cava is directed outside the body into an artificial heart-lung machine which is then connected to the aorta. During surgery, hypothermia is maintained at 20 degrees to 26 degrees. This slow metabolic and heart rate is very important. In an infant, it is even lower, 15 to 20 degrees Celsius. What is the reason why hypothermia should be obtained? It will stop the beating of the heart and it will quiet the heart. The heart basically or practically now it's quiet and it is bloodless because the venous return is already diverted outside the body. At this point, a bloodless and a quiet heart can now be opened and operated on. Third is valve replacement. Usually, valves are synthetic or donor valves, but before they use pig or cow valves. It is important that after surgery with valve replacement, an anticoagulant or antiplatelets are given. This prevents thrombi formation at the valve implantation site. It's also important to give prophylactic antibiotic. Fourth is a cardiac transplant. Children who have a hypoplastic left ventricle or a non-working left ventricle or extensive cardiomyopathy from any cause are candidates for heart transplant. They are usually maintained on ECMO as explained a while ago. Fifth is through the use of a pacemaker. A heart with an ineffective SA node function or a difficulty transmitting impulses from the SA node to the ventricles may have an artificial pacemaker inserted. This controls the heartbeat by stimulating the ventricles electronically. SA node is basically the pacemaker of the heart. It initiates every heartbeat. Now, an artificial pacemaker, once inserted in a child, has two components. One is the pulse generator and second are the wire leads. The pulse generator is placed directly under the skin in the subxiphoid process. It is where the battery is. And the wire leads, these are the ones placed in the epicardium. Because it's a battery, there's a lifespan. The lifespan is approximately 12 to 15 years battery life. It stops slowly, not abruptly. We should teach parents about the signs that the battery is already starting to not function well. We should also teach parents that the children should avoid getting near magnets, electrocautery, and also contact sports. Let us now discuss the pediatric heart diseases. There are two general classes. Congenital is the result of a congenital anomaly either because the heart developed inadequately in utero or the heart cannot adapt to extrauterine life for some reasons. Second is acquired. It is a healthy born heart to a diseased heart, or there is a complication of an existing heart problem. Congenital heart diseases are either acyanotic or cyanotic, as shown in the slide, but a second classification system, which is increased pulmonary blood flow, obstruction to blood flow leaving the heart, mixed blood flow of oxy and deoxy blood, and decreased pulmonary blood flow addresses hemodynamic and blood flow patterns rather than effect, compared to the previous acyanotic and cyanotic classifications. The new classifications allow a more uniform and predictable set of signs and symptoms. VSD or ventricular septal defect is an opening between the right and the left ventricle. It's the most common type of cardiac disorder, congenital cardiac disorder, which usually accounts 30% of all CHDs, or 2 in every 1,000 live birth. In this defect, blood that should go into the aorta is shunted back into the pulmonary circulation, resulting in right ventricular hypertrophy and increased pressure in the pulmonary artery, because pressure in the left ventricle is greater than the right. So there, again, blood shunts from left to right across the septum. Assessment findings: there's a pansystolic murmur. When you say pansystolic murmur, the murmur starts at S1 and extends up to S2. There's also a palpable thrill. A thrill is a vibratory sensation felt on the skin overlying the area of turbulence. It usually indicates that there is a loud heart murmur. For the management, small VSDs are up to 85% of all the cases. They are usually small that they close spontaneously. Moderate, they are easily resolved through cardiac catheterization. And large, over 3 millimeters in size, it must be operated on through an open heart surgery before 2 years of age, and this is to prevent pulmonary artery hypertension. Post-operatively, it's important to give prophylactic antibiotics for 6 months to prevent bacterial endocarditis. ASD, or atrial septal defect, is an opening between the right and the left atrium. Blood flow is from left to right, from oxy to deoxy blood, because of the stronger contraction of the left side of the heart. These causes increase in the volume in the right side of the heart. This generally results in ventricular hypertrophy and increased pulmonary artery blood flow, the same as in VSD. The assessment findings are the following, and the management: for small ASDs, cardiac catheterization, and large, open heart surgery. It is particularly important that ASDs be repaired, especially among girls, because if they grow old, it can cause emboli once they become pregnant. Atrioventricular canal defect, sometimes atrioventricular septal defect, is also an endocardial cushion defect which results from incomplete fusion of the septum of the heart at the junction of the atria and ventricles. Although blood flow is generally left to right, blood may flow between all the 4 chambers of the heart, and it has the same symptoms with that of ASD. Surgery will involve valve repair, as these defects are too large to close spontaneously. By looking at the picture, you can see that there is a problem of the valves closure, particularly the mitral and the tricuspid valve. Although rare in the general population, as many as 50% of children with trisomy 21 or Down syndrome have this defect. PDA, or patent ductus arteriosus, is the failure of the ductus arteriosus to close after birth. This closure should ideally begin with the first breath, up to 7 to 14 days, and complete closure should be in 3 months. The following are the assessment findings. Management: IV indomethacin or ibuprofen as a prostaglandin inhibitor is very effective. But if the drugs fail, cardiac catheterization or thoracotomy is effective. Rarely, cardiac cath or thoracotomy is used because most cases of PDA respond well to the drugs. Pulmonary stenosis is the narrowing of the pulmonary valve or the artery just distal to the valve. Stenosis or narrowing causes inability of the right ventricle to evacuate blood by way of pulmonary artery. The obstruction leads to right ventricular hypertrophy. The following are the assessment findings, and management is through balloon angioplasty by cardiac catheterization. This procedure is when a catheter with an inflated balloon at its tip is inserted and passed through the heart through the stenosed valve. As the balloon is inflated, it breaks the valve adhesions and relieves the stenosis. Aortic stenosis is the stricture of the aortic valve, which prevents blood to pass freely from the left ventricle to the aorta. Because the heart cannot force blood through the strictured valve or the narrowed valve, there is increased pressure and hypertrophy of the left ventricle. Typically, most children with aortic stenosis are asymptomatic. The following are the assessment findings, but if the stenosis is severe, signs and symptoms are also severe. This is because the affected valve carries oxygenated blood being delivered to our body cells. Management: beta blockers or calcium channel blockers can be given to reduce cardiac hypertrophy. Balloon valvuloplasty, or this involves the repair of the affected valve. It is the surgical treatment which involves dividing the stenotic valve or the strictured valve by dilating accompanying constrictive aortic ring. Or it could also involve artificial valve replacement of the aortic valve itself. After the surgery, again, anticoagulants, antiplatelets, and antibiotic prophylaxis are important. Coarctation of the aorta is the narrowing of the lumen of the aorta due to a constricting band, as shown in the picture. It's the leading cause of congestive heart failure, especially in the first few months of life. There are two locations, the preductal and the postductal. But regardless of the location, as shown in the picture, you will see that the constricture causes more blood flow in the upper part of the body and lesser blood flow in the lower part of the body. Assessment findings: there's upper extremity hypertension, lower extremity hypotension, which is usually a difference of 20 mmHg. 20 mmHg higher in the blood pressure in the upper extremities compared to the blood pressure in the lower extremities. Headache, vertigo, and epistaxis, again due to upper extremity higher blood flow. Absent femoral pulses because of less blood flow in the lower part of the body. In older children, there's also leg pain. Management is interventional angiography through a balloon catheter or cardiac catheterization or surgery. Transposition of the great arteries. The great arteries we are talking about are the aorta and pulmonary artery. This is where the aorta arises from the right ventricle instead of the left. On the other hand, the pulmonary artery arises from the left ventricle instead of the right. This is shown in the photo. This severe defect is incompatible with life. That is why the child, upon birth, is cyanotic, has an enlarged heart, and with a very low oxygen saturation. In most instances, atrial and ventricular septal defects also occur. Management: if there is no septal defect or if it is too small, a prostaglandin is given to keep the Duotus arteriosus patent. or it can also be done through a cardiac catheterization to enlarge the septal opening. In this case, it is important that the ductus arteriosus remains open. This is to make sure that somehow there is blood flow and there is even a little oxygenated blood being delivered to the cells. Surgical correction on transposition of the great vessels must be done at 1 week to 3 months, where the vessels are switched in a position. This is a very delicate surgery. Mostly, it has a poor prognosis. Total anomalous pulmonary venous return. This is when pulmonary veins return to right atrium or superior vena cava instead of the left atrium as they normally would. This disorder is often associated with an absent spleen because the pulmonary veins carry oxygenated blood but are attached to the right side of the heart. There is a problem with blood flow. So, child is cyanotic, tires easily, and may develop right side heart failure. Management surgery involves reimplanting the pulmonary veins into the left atrium so that oxyblood will be carried out again by the aorta to the systemic circulation. But until surgery can be carried out, a balloon atrial septal pull-through will enlarge a small foramen ovale. Again, these are cases where we want the fetal structures to remain open so that there is still oxygenated blood flow somehow. The same with the third management, giving of prostaglandins. This will help keep another fetal structure, ductus arteriosus. Trunous Arteriosus, as seen in the photo, is where a major artery or trunk arises from the left and right ventricle. This is instead of a separate aorta and a separate pulmonary artery. This is usually accompanied by VSD. Because of the abnormal blood flow, the child is cyanotic and presents with murmur. Management is an open heart surgery. Again, recall the principles of ECMO. The repair involves restructuring the common trunk to create separate vessels, the aorta and the pulmonary artery. Some children need a second surgical procedure by school age because the graft that was previously inserted has been outgrown because the child grows bigger. Hypoplastic left heart syndrome. In the photo, you will see there is an underdeveloped left ventricle. This is when left ventricle is non-functional. It lacks adequate strength to pump blood into the systemic circulation. This causes the right ventricle to hypertrophy as it tries to maintain the entire heart action. Also, the syndrome accompanies mitral or aortic valve atresia. Obviously, the child is cyanotic, as the oxygenated blood is shunted across foramen ovale because of greater pressure on the right. Management, prostaglandin therapy, again to maintain PDA. We want to make sure that the fetal structures remain open. This will increase blood supply to the aorta. Also, an inhaled nitrogen combined with oxygen can be given. This will decrease PO2, increasing the pulmonary resistance. Heart transplant is the ultimate answer for prolonging the child's life, although surgery has limited success, but there's a great deal of research being done until now. Tricuspid atresia is an extremely serious disorder because the tricuspid valve is completely closed. Atresia means closure. where there is no blood flow from the right atrium to the right ventricle. Again, as I have previously mentioned about the foramen ovale and ductus arteriosus, in these cases, we want these fetal structures to remain open, because as these fetal structures are open, the child can obtain adequate oxygenation. Closure will develop extreme cyanosis, tachycardia, and dyspnea. Management, again, to remain the fetal structures open, prostaglandins are given. Second is an open heart surgery, again through ECMO. One is a construction of a vena cava to a pulmonary artery shunt. This will allow an oxygenated blood to reach the lungs, or a Fontan procedure or Glenn shunt baffle. This restructures the abnormality of the right side of the heart. Tetralogy of Fallot involves 4 anomalies: pulmonary stenosis, VSD, dextroposition of the aorta, and hypertrophy of the right ventricle. A number of children with TOF shows a deletion abnormality of chromosome 22. The following are the assessment findings. Management is a Brock procedure done at 1 to 2 years of age. During the waiting time, administer oxygen, especially during a hypoxic episode. Place in a knee chest position. This will trap blood in the lower extremities and keep the heart from being overwhelmed. If you see a child with TOF in this position, the child looks calm. Just let the child be in that position and observe. Administer morphine sulfate and propranolol. Morphine will reduce the symptoms, and Inderal, beta blocker, will aid in pulmonary artery dilation. This is the propranolol. Fourth is the Blalock-Taussig procedure, which creates a shunt between the aorta and the pulmonary artery. This is only temporary or palliative, as the Brock procedure is the final repair. The Blalock-Taussig procedure will only create a ductus arteriosus, again to allow blood flow. The next group of diseases we will discuss are the acquired heart diseases: congestive heart failure, persistent pulmonary hypertension, rheumatic fever, and Kawasaki disease. Congestive heart failure occurs when the myocardium of the heart cannot pump and circulate enough blood to supply oxygen and nutrients to body cells. Box 41.6 shows a child with heart failure. And among all of these findings, tachycardia is the first finding that you can expect in a child with congestive heart failure or CHF. Also, in this condition, there are 2 major problems. One is congestion, because the heart cannot anymore pump blood out of the heart effectively. Heart failure is its continuous attempt to pump, but there's already inability of the myocardium to pump effectively. Drug therapy is very effective in treating CHF, but the underlying cause of the CHF must be treated as well. For example, if the cause of CHF is a congenital heart defect, that defect must be treated as well, because if untreated, CHF might be evident or might return again. What are these drug therapies? These therapy for heart failure consists of reducing the workload of the heart. One is digitalis. It slows the heart rate and strengthens the cardiac function. It must be given 1 hour before or 2 hours after feeding. take epical pulse for 1 full minute. Because it slows heart rate, do not give digitalis if epical pulse is low. Monitor potassium, monitor digoxin levels because it can cause digitalis toxicity. So the following are the signs of toxicity. Diuretics. It evacuates accumulated fluid, reduces preload or volume of blood in the ventricles after diastole. Samples are furosemide or spironolactone. Take note that it's important to choose these two diuretics, especially spironolactone, but furosemide is a potent diuretic which will relieve congestion right away. You must monitor very well potassium levels to prevent digitalis toxicity. It decreases total body water and increases urine output, so check for blood pressure. Do not give diuretics if the blood pressure is low. Third are vasodilators. They reduce afterload or the resistance of the left ventricle. It must be overcome in order to circulate blood. Hydralazine is an arterial vasodilator. Nifedipine is a calcium channel blocker. Nitroprusside is a direct-acting vasodilator. And captopril is an ACE inhibitor. These are all effective. Persistent pulmonary hypertension, or PPHN, occurs when pulmonary vascular resistance present at birth because of an unopened alveoli fails to fall to normal. This occurs because hypoxia and acidosis from respiratory difficulty cause vasoconstriction of the pulmonary artery. As shown in the photo, PPHN may result from many neonatal disorders such as RDS, TTN, meconium aspiration, hernia, and the like. Assessment findings show tachypnea, low oxygen saturations, and echocardiogram shows right-to-left shunting across patent ductus or foramen ovale. Treatment for PPHN consists of supportive therapy. It includes giving of oxygen, IV glucose, antibiotics, dopamine, sildenafil, sodium bicarb, nitric oxide, and even ECMO. Serious threat to newborns would include severe respiratory distress and prolonged therapy. And children with PPHN may be left also with neurologic deficits or neurologic challenges. This is because of severe hypoxia and inadequate brain cell oxygen perfusion. Rheumatic fever is an autoimmune disease, which basically means your own immune system attacked your own body cells. This is believed to be caused by antibody cross-reactivity occurring as a reaction to group A beta hemolytic streptococcal infection. This rheumatic fever usually follows pharyngitis, tonsillitis, scarlet fever, or impetigo. All these infections are caused by group A beta hemolytic streptococcus. The symptoms of streptococcal infection usually subside in a few days with or without antimicrobial therapy. After 1 to 3 weeks, however, if the child was not treated well, onset of rheumatic fever symptoms can begin. It occurs most often in children 6 to 15 years, but the peak incidence is among children 8 years old. The illness is so named because of its similarity in presentation to rheumatism, hence rheumatic fever. Box 41.9 shows a child with rheumatic fever. According to the Jones criteria, Rheumatic fever has major and minor symptoms. The major symptoms are 5. These are the ones shown here in bold letters. Carditis involves the cardiovascular system. Erythema marginatum involves the skin. Subcutaneous nodules, the skin also. Polyarthritis, skeletal system. And chorea, or the sudden, jerky, involuntary movements of the hands or the feet. This involves the nervous system. If you can see, this involves many body systems, but rheumatic fever's carditis is the most fatal one. Hence, this condition is included in the pediatric cardiovascular diseases. The full course of rheumatic fever is usually 6 to 8 weeks. It is important that bed rest be maintained during the acute phase where there is no CHF yet, ESR decreases, C-reactive protein return to normal. ESR and C-reactive protein are signs or laboratory tests that indicate inflammation, and apical pulse return to normal. Management as a course of penicillin therapy can be given, single IM of benzathine penicillin also. This will eliminate group A beta hemolytic streptococcal infection. It's important to finish the entire treatment. Ibuprofen or corticosteroids to reduce inflammation and pain, phenobarb and diazepam for chorea, digoxin and diuretic if with CHF, and some children may need mitral valve replacement to restore heart function if there is valve destruction from Astroph's bodies or fibrin deposits. These are caused by the autoimmune process. Kawasaki disease or mucocutaneous lymph node syndrome is a febrile, meaning the child evidently has fever, a multi-system disorder that occurs almost exclusively in children before puberty. Peak incidence is in boys under 4 years of age. Cause is generally unknown, but apparently it develops in genetically predisposed children after exposure to perhaps upper respiratory tract infection. After URTI, there is an altered immune function. This increases antibody production, which creates a circulating immune antibody-antigen complexes causing inflammation. What happens next? The inflammation is the vasculitis. It's the inflammation of the blood vessels. It is the principal and life-threatening finding because it can lead to formation of aneurysms and myocardial infarction. Box 41.10 shows the assessment findings in a child with Kawasaki disease. To be diagnosed, a child must manifest fever and 4 findings in box 41.11 plus echocardiograph results confirmation of the artery disease. There are 4 phases. Acute phase, stage 1 is the first week. There is usually fever, 39 to 40 degrees Celsius, that does not respond to any antipyretics. ESR, or the erythrocyte sedimentation rate, which shows inflammation, is elevated. Second is the subacute phase, about 10 days after the onset. There shows desquamation. The platelet rises and thrombus also forms. So in this phase, aneurysms may actually occur. Third is convalescent phase, stage 2, 25th to 40th day. The child seems to be recovering. And stage 3, 40th day until ESR returns to normal, where we can say that the child now is already well again. Management. Aspirin or ibuprofen decreases inflammation and blocks platelet aggregation. This is important not specifically for fever, but to prevent thrombus formation, which is a complication of Kawasaki disease that can lead to further problems. Abscimab is also a platelet receptor inhibitor to prevent thrombus formation, which can cause myocardial infarction. This is specific for Kawasaki disease. IVIG reduces immune response, but children under IVIG should not receive immunization while taking this drug. The immunization will be ineffective. Fourth, avoid steroids as anti-inflammatory drugs. Steroids increase aneurysm formation. Fifth, if the child is left with coronary artery diseases, in some cases there is stenosis of coronary artery, a coronary artery bypass surgery may be necessary in the future. We should also tell mothers that most children with Kawasaki disease recover fully as long as management is done correctly.